daily cases. We are now here gathered together in this beautiful, which is very near this place, Syracuse. Can you believe it's more than 2,500 years old? Actually, 2,500 years ago, they were having sieges and having naval battles, and even had flipping Archimedes living here. What is this?
I put that in there.
Oh, you put that in there.
Yeah, so you can use this.
I don't need it.
You don't need a pointer to change?
Well, maybe.
The pointer is this. Okay, this one right here, right in the middle. Okay. And if you want to change your slides, you can change it.
Thank you. So, where was I? Oh yes, Syracuse. So this is the island. This is also quite close by. The next one right here, it doesn't work, so I'll just do it manually. This is Noto, also close by, very beautiful city. And this is what every Sicilian, when they open their curtains in the morning, see. So it's not bad at all. Or every afternoon when they come home from work and have a cheeky pint, you know, what a nice view. This is my view when I wake up in the morning. This is Rotterdam. This is the biggest port in the world outside of China. So they have a lot of people working there. And also it's a lovely city. This is the old bit that wasn't bombarded, and this is the new bit. And we have a beautiful bridge here as well. It's famous in the Netherlands. It's called the Erasmusbrug, the Erasmus Bridge. And when it's very windy, it starts to wobble a little bit. Yeah, and if you're really unlucky, you can wobble off of it, so be careful. As I said, I'm going to have a quick presentation, 3 cases, very simple. I don't have a lot of pictures. We're not going to discuss a lot of techniques, so you don't have to think, you just have to listen. So, the first case is a typical whiplash case that I actually see quite a lot of in my practice. This man had a crash into the side of the car. There was it was in October, I have a picture of it. He did walk away with some tinnitus and some stiff muscles in his neck. 3 days after, he started to get nauseous, sensitive to light, memory loss, headaches, neck pain, also very important of course. 3 years later, he was still having that neck pain. Stiff muscles, headaches, actually a lot of other symptoms. They were getting better, you know, that I prescribed to the concussion part of it, because it was quite a smack, as you can see. This was the accident actually. And if you see this hole in the car, this here was made by his head. So it was quite a smack. So he had presented himself, he's been everywhere. So to physical therapists, osteopaths, he done dry needling of the muscles of the neck, and that was the only thing that actually helped him for a while. And that's a key word. I'm going to come back to that, why that helps for a while. So I examined him, very stiff muscles, he had pain in his neck, very sensitive occipital muscles. The MRI scan that it didn't see much. We don't have a digital motion X-ray in the Netherlands. Sometimes a radiologist would venture to make a flexion extension picture or a X-ray, but not all of them. They say, oh well, just the straight is enough. So can I rule out upper cervical instability, which is C0, C1, C2? I really can't. I have to send them to Germany, I've sent them to London for further examination. So it's still a little bit, very much unknown in the Netherlands. So what we sometimes see here with ligament instability in the cervical spine, if you take a look at the X-ray, you see the military neck, see the loss of the normal healthy curvature of it, and that is sometimes what you see. You can see that sometimes on the MRI scan as well. So what did I do? If we come back to his clinical signs for just a second. So he was complaining about neck pain, a lot of stiff muscles, and he went to a physical therapist that does dry needling, and that helped him loosen up the muscles, but the tension always came back. And he was puzzled why, because when he was after the treatment with the dry needling, it felt really good. So there's always a reason why muscles try to contract again, and that's because it's compensating for weak ligaments in this case. So if you see this big ligament here in the middle, I always explain this like a little bit plastically to my patients. This is a big ligament, like a big duct tape going from your skull down to your coccyx, and it's been stretched out. So the muscles then need to compensate for really, for the lack of stability. One of the other sides, so Stephen mentioned I do a lot of chiropractic treatment, that's also true, is that they crack themselves. They always say, oh, I have pain in my neck, and then they crack themselves, or they let it do somewhere else, and they said, oh, it feels good, but it always comes back. So the subluxation or the pain in the neck, or the tendency to want to crack yourself, it always comes back quite quickly. And that is also in my, well, not in my opinion, it's other people's opinions, but also in mine, of course, weak ligaments. So, Hackett Hanwell Prolotherapy, I basically do as much as I can the facet joints from C2 down to TH8, which is also somewhere mid-thoracic. I always like to do it way down mid-thoracic, because I feel that helps better than only treating the neck itself. I do the supraspinous and the interspinous ligaments and the nuchal line here on the skull with just regular prolotherapy. And in this case, we need some neuroprolotherapy or PIT to his occipital nerves. And sometimes when people are a little bit scared of injections, I just start off with that. And sometimes that alleviates the pain for a large part already, treating the occipital nerves and the trigger points in the trapezius region. Did that for a few times, and he said he has come back since, and he's already experienced a large relief in his neck pain and his ability to focus his eyes and many of his other symptoms. So I also want to talk about a little bit about malalignment of the cervical spine. So in this case, it wasn't quite as pronounced, but some people, they really, if you palpate them, you can really feel that the cervical bones are out of place. So we adjust that. We put it back into place. I don't usually start with that in these cases. I usually wait until the ligaments are a little bit stronger, because people who have a hypermobility of the neck or of the lower back, once we adjust it, or one of our chiropractors do it, they walk outside the clinic and they get in the car like this and they say, oh, I felt it going out again. That's typical of instability cases. So it doesn't make much sense in the beginning to start to really manipulate it. I usually wait a little bit with that until later. But then, because if we do a manipulation, the manipulation or the correction will actually hold. And that is the goal, of course. All right, case 2, it's going quick. So this is also quite an interesting case. So a low back pain after a herniated disc surgery. So this man, early 70s, starting having low back pains with radiation in both legs, went to a neurologist, he said you have a hernia, got a corticosteroid injection, that helped really well, but the pain came back after 2 weeks. So they scheduled him for an operation. It went well for a month this time, and he had a severe stabbing low back pain all of a sudden, really central, no radiation this time. So they performed a new MRI scan, and then they said, oh, everything is okay, operation was a success, but the patient is basically dying of pain, so all right. And especially, he said, when he was transitioning from lying down to standing, or the other way around, and the way I usually see this, that people in the waiting room, they're usually standing up, they're saying, oh, can I just stand, it just feels better than sitting down. And when I ask them to get prone on the examination table, and they go like this, they're like, oh, they almost stop in their tracks, and like, oh, they have to like ease into it a little bit. Same when they're on their prone on their bellies. When I ask them to turn around or come back up, you really have to like ease. And in my eyes, or in my experience, that is very indicative of a disc pain or disc problem. So is it discogenic pain, a disc problem after operation? What about the malalignment in the SI joint? Is there any relationship? Maybe that might be the cause of the pain, because it's the cause of a lot of joint pain, as Dr. Abby said this morning. Terrific lecture, by the way. So we see that a lot in our clinic, which would affect the lumbar spine. Or is it really just the SI joint and the surrounding ligaments that's causing the pain? It wasn't, if you pressed on his SI joint, you could press it on it with my elbow, it didn't hurt at all. So I didn't think that was a big problem. So really something that is quite rare in my practice, somebody with really mostly discogenic pain. I usually see people with painful SI joints and everything else. But he did have a bit of a malalignment. So where does that come from? I don't know about you, Dr. Abby. You know, I always said go buy the book by Dr. Wolf Schamberger, but now I'm going to say buy this guy's book, obviously, because it talks about the malalignment of the pelvis, and you know, you can see pronation, and you get internal rotation at the knee, and then you've got the whole cascade going on. As chiropractors, well, I'm not officially a chiropractor, but I do it a lot. The people that work with us in our clinic, they are chiropractors. They usually think from the pelvis, either down or up. There are other chiropractors that think from the upper cervical part and down and up. And there is also, I believe, the group is also from Australia. It's called the chirodontics. Do you know that? The jaw. Yeah, they look at the teeth first. They say, oh yeah, if you've got a malalignment, a malocclusion, then you have your neck like this, and you have to compensate in your mid-thoracic, and then your lumbar goes out. So I see it as one big continuum. It basically feeds each other. And in our clinic, we do everything except adjusting the occlusion, and also not yet the orthotics, but I'll probably have to incorporate that at some point. So this is actually a very valuable concept to have, you know, in your practice, because you see the relationships between the different problems that people have. And in this case, you know, if your SI joint is twisted, you get an asymmetric load on your discus in the lower back, and that can also give trouble. It wasn't that bad in this man's case. So what did I do? We're going to have a different lecture about this on the sweet caudal epidural injection by Dr. Lisa herself. I usually also start with the glucose 5% injections, usually 10 to 20 millimeters. Millimeters, because you have to think how many milliliters you put in, how many centimeters up you can reach. And usually this man was also quite tall, as is quite usual in the Netherlands, so I have to put a little bit more volume in there just to reach that disc. Depending on the pain, I use a frequency of 1 to twice per week for 2 to 4 weeks, just to get that started. And if people say, oh, I feel better, then we can maybe put some more time in between. Or if they say, oh, it's not really quite there yet, then I can just continue with that pattern. I also sometimes I add Procaine 1%, and I dilute it down to 0.5%. It's also against swelling, and also does have some good effects on the nerves as well. And in severe cases, you know, don't look at me funny, but I also use corticosteroids. Usually 20 milligrams is in my eyes, a mild dose. You can go higher, but it's really just a little bit extra, because sometimes people come in, they say, you know, I can't function, I haven't slept properly for 2-3 weeks. You know, I give them a little bit stronger, so at least they are in a little bit safer, or they, as we say in the Netherlands, they are a little bit on calm seas. So this is a little bit how it looks like with the caudal epidural. It's very safe. Only takes a few seconds to do, and it's quite effective as well. So now we've gone down from the cervical spine. Mid-thoracic is also a very important subject. I won't talk about in this presentation, because I see a lot of mid-thoracic pain. We've gone down to the lumbar spine, and now we're going to go to the SI joint. Oh yeah, I also want to say, always remember Biotensegrity. You can think, okay, I'm treating this man's disc, and that's it. I'm not doing anything else. Then you're only doing half of the work. If you think like a prolotherapist, you always have to treat the Biotensegrity of the lumbar spine, because that's the problem. That's the reason he got a problem in the first place. And you might want to be able to take a look at the malalignment syndrome. So that is really getting to the root cause. So remember the Biotensegrity. So in this man, I also treat the facet joints of the lower lumbar spine, the SI joints on both sides, and the iliolumbar ligaments. Very important in my eyes. Oh, this is a small case without prolotherapy. This is my mystery case. Just, oh sorry, one little word about it. This young woman, 30 years old, had come with me, intermittent severe pain in the hands, arms, shoulders, also in the ankle and the feet. She had been to many doctors. Nobody was able to figure it out, me neither. So I thought, well, I'm going to check B12, vitamin B12, and it was very low. I don't quite remember how much, but it was very low. I gave her a few B12 shots. She started feeling better. Her mom came in as well with all kinds of complaints. I gave her B12 injections. They both, a 30-year-old woman, she needed to take a nap in the middle of the day. She doesn't need that nap anymore because she was so tired and everything. She feels fresh and she feels young and strong again, as she should. So just to show you, it's not only, it's not always a biomechanical or a musculoskeletal thing. So what I also see a lot of in my practice is women who've had a baby and who still have a lot of low back pain or pelvic pain in this case. So this is a 35-year-old woman with a lot of pelvic pain since 6 years when she got her first child, or her only child I should say. And the pain in her pelvis has even prevented her from trying to make more children. You know, she said, I always wanted to have 3-4 children, but now I can't even I couldn't even take care of one. So it really, she really felt bad about it. And until a few, maybe like 10 years ago in the Netherlands, so there was this ruling thought that, oh, these women, that's all, attention seeking, as you said, and it doesn't exist. And there was even an old gynecologist on national TV that said, oh, when I was young in training, women didn't have that. There was no pelvic pain after pregnancy. It doesn't exist. I mean, it's all bullshit basically. So we've gone, and this was maybe 10 years ago on national TV. I was flabbergasted when I saw it. So she was complaining about low back pain, a little bit of radiation down to the buttock area and the thigh area on one side, and it affected her quality of life tremendously. She gave herself a 4.5 out of 10. I mean, imagine that, at 35 years old. So this is, almost exactly where she also had pain on the left side then, which come from these ligaments. So these ligaments, you've all seen it, and you've probably all treated this many times already. And if you haven't, please start, because it's such a rewarding procedure. The iliolumbar ligaments, the sacroiliac ligaments, and the lower ligaments down here, the sacrotuberous, sacrospinous ligaments, they all have to form a sling, and that goes up to the lumbar spine, so that has to be tight and it has to be strong. Dr. Becot, he went into the diagnosis of this problem a little bit, so I'm not going to go too much into that. The active straight leg raise test. I couldn't find a good picture. In this case, the leg is quite high. It doesn't have to go all the way up. It's just a little bit, just to see how much force she can produce, because when she lifts up her leg like this, the SI joint is the only contact point with the examination table. So this is a great test to see how much or how well she can transfer force through the SI joint ligaments. You can test it with the pelvic pelt on and off, and you can see the difference in everything. But it all boils down to the strength of the ligaments, so they don't heal properly after this pregnancy. But they can, and they will heal very nicely if you just give it time and you give it enough treatment with prolotherapy or PRP. So in this case also with ligamentous laxity, what you often also see is that they do also have a malalignment that we also have to correct at some point, because because in the beginning these ligaments are loose, and if you do a correction it won't hold. So you have to ease it a little bit, ease it off. You have to use it a little bit later in the treatment cycle. So again, small, like Dr. Abby would say, she may be having a foot problem that causes this. It probably is, in the beginning, why some women are prone to having this problem and some women are not. It might just be that the pregnancy is the last drop, for them to start developing problems there. So again, that's called the malalignment syndrome. It has many names, but it comes down to the same thing. Again, a picture of the ligaments, and that was my presentation. Thank you very much.